Welcome to Aetcm, the emergency medicine channel. Shall we see?
Yeah.
24 male presented to ER with complaints of redness and watering of both eye for past 3 days. Initial 10-second assessment, airway is patent with no gargling of circulation, stridor, hoarseness of voice. Breathing wise, saturation of 98% with respiratory rate of 20 per minute, bilateral air entry present. Circulation, pulse rate of 80 per minute, BP of 120/80 with all peripheral pulse palpable, S1 S2 present. Disability GCS E1 V5 M6 with GRBS of
E4 V5 M6.
E4 V5 M6, GRBS of 150 with the exposure by temperature is febrile. So sample history: 24-year-old male presented to ER with gradual onset redness, complaints of redness and watery of bilateral both eyes for the past 3 days. It was gradual in onset. First redness started on right eye, then left eye within 24 hours, associated with foreign body sensation, itching, which was more on night, with mild mucopurulent discharge on waking up. There is history of contact lens use for this patient prior to this onset. There is no blurring of vision, photophobia, pain, no history of trauma, chemical exposure, no URTA or LRTA feature, no history of fever, no history of any ocular surgery, drug allergies or previous similar history, no history of pets in the at house or any contact to pets.
Okay. Any similar history in the family? Anyone else? No. Okay.
So on examination, patient is conscious oriented, systemic examination as within normal limit. On ocular examination, inspection wise, bilateral conjunctiva is conjected, which is diffuse more in the fornixes with mild eyelid edema present.
Okay.
Mucopurulent discharge was found at the lid with visual acuity of 6/6. Cornea appears to be clear, not cloudy, and pupils are equal and reactive.
Reactive.
Then on palpation wise, there is no hardness in the eye.
Where do you get hardness?
In glaucoma.
Yeah.
Acute glaucoma. Then we did a fluorescent study to rule out any corneal involvement, which shows cornea is intact with no abrasions or scarring in cornea. So our professional, since the patient is presented with a 3 days history of redness, watery eye, which first started in one eye, then spread to other, we came with no corneal involvement. We came to a diagnosis of acute conjunctivitis. So conjunctivitis is actually the inflammation of conjunctiva, which is the outer layer of our eye, which have two parts, bulbar conjunctiva and palpebral conjunctiva. Its inflammation is called conjunctivitis, which is a most common cause of red eye. It is usually most common is viral in etiology, which is self-limiting condition.
What are the other causes of red eye? Differential diagnosis for red eye in the ER.
Red eye could be mild or benign cases as well as severe cases. Most severe cases like ocular emergencies can be presented at red eye. So most common mild cases is chalazion, corneal abrasion, phlebitis, hydrolium, ectrion, corneal abrasions, ultrasound keratitis. Most common causes benign conditions are chalazion, hydrolium, blepharitis, darkocystitis, ectropion, then conjunctivitis, viral conjunctivitis, allergic conjunctivitis. These are like benign conditions.
Benign conditions.
That does not affect our vision. So affecting vision, keratitis, corneal abrasion, corneal ulcer, corneal foreign body
should be given high priority.
Yes, chemical burn injuries,
chemical burn injuries,
Stephen-Johnson syndrome,
any trauma, penetrating trauma, any case, orbital cellulitis,
receptal cellulitis,
uveitis, scleritis, endophthalmitis, and also the most the one stony hard glaucoma,
acute closure glaucoma.
Okay, these are of high importance. So your goal would be to differentiate each one of them distinctively. So moving on to conjunctivitis, as you rightly told, the etiology can be viral, bacterial, or it can be allergic also. So how would you differentiate a bacterial from viral, bacterial and viral from allergic? Start with viral.
Viral conjunctivitis is it's most common.
Okay.
Their most common cause is
Adenovirus.
which can even cause epidemic keratoconjunctivitis.
Exactly.
Which is highly contagious. There's a prodromal phase of cough, fever, myalgia, malaise will be
So
there.
mostly there will
associated
be
with
signs of some upper respiratory tract infections.
infection. Then symptoms include red eyes, photophobia, foreign body sensation, tearing. There is no eye pain unless there is some degree of keratitis. So physical examination where there will be unilateral or bilateral conjunctival congestion along with chemosis and small subconjunctival hemorrhages. In case of adenovirus, it could be seen. Then there is preauricular lymphadenopathy is more common in viral conjunctivitis.
What kind of discharge do you normally have?
Viral
Eye discharge, viral.
watery eye discharge.
Watery discharge.
Then when slit lamp examination, there will be small regular follicles seen in palpable conjunctiva and punctate lesions in fluorescent staining in case of if there is
So
keratitis.
fluorescein staining is a very important staining technique that has to be done in the ER for any case of red eye. Why? Because we need to rule out any corneal ulcer or if at all keratitis is present or not. That will be the deciding factor for that. Right.
So, treatment of viral conjunctivitis consists of symptomatic management, including cold compression, ocular decongestions, and artificial tears. And it can take 1 to 3 months to run its course, and it's very contagious.
Okay.
And we have to instruct the patient to wash their hands frequently, avoid touching the eyes, and also to use separate towels. And examiner should also wear a glove to avoid self exposure, and everything should be decongested like slit lamp and other ocular
Decontamination should be done.
decontamination should be done.
Okay.
And in case of viral,
We did viral now. We'll go to bacterial.
So bacterial conjunctivitis is also painless, unilateral or bilateral. There will be purulent, mucopurulent discharge which is sticky.
Characteristic would be you sleep and when you get up, it be sticky. Yes.
Chemosis is also very common. Preauricular lymphadenopathy.
Chemosis is swelling of the conjunctiva. Okay.
Preauricular lymphadenopathy is usually absent except in gonococcal or chlamydial infection.
Okay.
Then most typical organisms with Staphylococcus or Streptococcus, which mostly the case is self-limiting, but trimethoprim is very effective, but should be avoided in sulfur drug allergies.
Yes, but your patient, there was one more agent. Contact lens usage. Yeah,
so
they are
prone for pseudomonas infection.
Exactly.
So we should also add fluoroquinolones eye drops in addition to other antibacterial things.
Okay.
So in case of chlamydia and gonococcal chlamydial conjunctivitis is most common cause of ophthalmia neonatorum and gonococcal conjunctivitis is a cause of ophthalmia neonatorum. And chlamydial conjunctivitis is also mostly seen in newborns.
Okay.
So in case of this treatment also include antibiotics. In case of contact lens, fluoroquinolones should be added along with other instruction to avoid contamination, self-contamination and also spread to other people.
Okay.
Then in case of allergic conjunctivitis, mostly the discharge is watery and redness and itching is also there. There's erythematous swollen eyelids and the injection and edema of conjunctiva with papillae, which is irregular papillae seen in the inferior conjunctiva. Then treatment include cold compression. This allergic conjunctivitis is mostly bilateral. There is no unilateral.
And also there will be a cyclic this thing according to some exposure or seasonal variation. Yes.
So treatment include cold compression 4 times a day with the topical drops and artificial tears. We can also take topical antihistamines, decongestant, mast cell stabilizer.
You have something known as nefazolin, which would have both decongestants and also it would have chlorpheniramine maleate as topical eye drops. There is also olapartine eye drops. So all this would help decongestion, right?
If when in doubt, if after a history and physical examination we are not at all certain whether the conjunctivitis is viral or bacterial, we should always prescribe ocular antibiotics until the patient is re-examined with the ophthalmologist in case of an ER patient.
Correct. Right.
Then also should steroids in severe cases of allergic conjunctivitis, we should severe symptoms may justify the use of topical steroids, but we should avoid it.
But we should always see one thing that we should always notice: usage of steroids should be very delicately thought about when it comes to ophthal cases. If at all you think about giving steroids, it's always better to involve Department of Ophthalmology into the case, because things can go anyway. So it's better to take the call after getting ophthal on the floor. So today's topic of discussion was conjunctivitis. We discussed about the differential diagnosis of red eye. What are the benign causes of red eye? What are the most life-threatening or more emergent cases of red eye that has to be given more priority in the ER? We told about what are the types of conjunctivitis, how to distinguish them, what are the different treatment modalities for conjunctivitis, and also about contact lens usage and what has to be prescribed for them, Pseudomonas against, so those antibiotics should be prescribed, and when to get ophthalmology consult. I guess that concludes the topic. Thank you.